Hey guys, good afternoon, everyone.
Hello.
Hey, hey. So we have Matt, we have Shay, Shannon, Steve, Jenna. Where's Alicia? Alicia, is you there? Hmm.
Oh, she's cycle. He's the middle.
Okay. Hey, Alicia, can you hear us? You're right. Shit. All right, guys, let's talk about atrial fibrillation today. Uh, Atrial fibrillation is the most common heart arrhythmia in adults. Uh, it affects mainly elderly. You know, if you look at people above the age of 80, about 15%, above the age of 70 is about 5 to 10% have atrial fibrillation, and it's a really pretty common disease. Atrial fibrillation, as far as pathophysiology, you have one is the lone AFib, which is most of the time is genetic. We really don't have like certain genes, like Mendelian kind of genes, like Marfan or Hockham or anything like that. But we know that about 10-15% of AFibs are lone AFibs and they are familial AFibs. In other words, you have multiple family members with atrial fibrillation, and these patients usually start early in life after 40s or 50s and before 70 years of age. Also, atrial fibrillation seems to be common in people with hypertension, morbid obesity, diabetes, and heart failure with both preserved and reduced ejection fraction. The increased actually prevalence of obesity is increasing the likelihood of having atrial fibrillation in this Asian population. Also, coronary artery disease increase the likelihood of having AFib, lung disease, COPD. As you know, there's a close proximity between the atria and the lungs, and irritation of the lungs can actually create and maintain atrial fibrillation. Also, in the setting of pneumonia, irritation, lung cancer, and so forth, there is certain AFibs. They happen as kind of when you have a fever and infection, when you have infection, sepsis, when you have surgery, you get atrial fibrillation, what we call post-op AFib. Critically ill patients, they tend to have atrial fibrillation, especially if they are elderly. Certainly not everybody with sepsis or lung or pneumonia or infection or ICU admission gonna have atrial fibrillation, but people with certain predisposition, they get atrial fibrillation. When it comes to recognition of atrial fibrillation, 12 lead EKG is the standards of the gold standards when it comes to diagnosing atrial fibrillation. But certainly, if you have somebody with devices and loop recorders, makers, ICDs, they have AFib, so you have to also label them as AFib patients. There's a huge debate about, for how long do you have AFib or mode switch on device, whoever does some devices, especially people in the clinic, when you have mode switch or, AFib on devices, for how long do you have to have AFib to label your patient as AFib and start anticoagulation? Really a huge debate, 6 hours, 12 hours, 1 hour, half an hour. So if patient has history of stroke or chest vascular is high, I tend to use half an hour. And for you, if you see more than half an hour recurrent on devices, as labeled as atrial fibrillation, then you have to really start thinking about diagnosing this patient with paroxysmal atrial fibrillation and start thinking about Chad's vascular your patient and starting anticoagulation. Now, not every mode switch is really a mode is AFib. Sometimes the device will do mode switch because of non-sustained atrial tachycardia, oversensing of the atrial channel, and so forth. So you have to really think about seeing mode switch in devices. And whoever I thought that I'm talking to electrophysiologists. So mode switch, the device will have certain modes. The device will switch if the atrial rate in the atrial channel exceeds 170 beats per minute. So that's what we call mode switch. So the device will mode switch in the sense that instead of pacing and pacing sensing in the atrium, it will sense in the atrium and stop pacing in the atrium, and we have what we call the VVI mode in the device. So in other words, I'm trying to not to complicate stuff, but when you see AFib in the device, just be careful that it's really AFib and make sure that it's above half an hour each episode or above 1% percentage-wise to label your patient as atrial fibrillation. Back to the clinical AFib, when it comes to atrial fibrillation management, obviously you really need to identify your ejection fraction in this patient. That's number one. Number two is you have to look at the way to manage atrial fibrillation by looking at the rate, rhythm, and anticoagulation. So let's talk about anticoagulation. It's the most important aspect of managing atrial fibrillation patient is to identify the need of anticoagulation. Why? Because as you know, the AFib increases your stroke risk by 5 times. And atrial fibrillation is one of the most important causes of strokes. About 25 to 30% of strokes happen because of atrial fibrillation. It is usually devastating when you have stroke related to atrial fibrillation. The way I tell my patient that the heart is a big blood vessel and clots forming in the heart because of AFib, they tend to be large in different areas of the brain in huge magnitudes. So you have to be very, very careful when you have atrial fibrillation about considering anticoagulation. And that's, in my opinion, the most important aspect for you guys when it comes to atrial fibrillation management, to identify the need for anticoagulation. Initially, before 2010, it was CHAS-2 score. It was in the Annals of Internal Medicine article that here, if we look at certain stuff, you can identify the risk, and based on that risk, you start giving blood thinners to your patients. This article should have been actually in the New England Journal of Medicine, most prestigious, journal, but it did not. People did not really realize the magnitude of stroke and atrial fibrillation until late. Beyond 2010, we started actually using the CHADS VASC score, CHADS VASC score. So part of standards of care, best practices in terms of managing your atrial fibrillation patient, you have to CHADS VASC score each patient with atrial fibrillation. So in your note, you have to mention any patient with atrial fibrillation, you have to mention ejection fraction, and you have to mention CHADS VASC score. You have to. Paroxysmal, persistent, long-lasting persistent, and we'll talk about that. And you have to mention CHADS VASC score is 2, 3, 4, whatever. 1 or 0, you don't need to use anticoagulation. I use it. I tend to use anyone with 1 or more, but certainly anyone with 2 or more, you have to start actually. So anyone with 2 or more, you have to start anticoagulation. If you're not going to start anticoagulation in this patient, you have to You have to do to mention a reason. You know, high fall risk, bleeding risk, anemia, chronic anemia, end-stage kidney disease, cannot, you know, dizziness, you know, again, you know, history of GI bleed, history of brain bleed, and stuff like that. So always you have to mention the reason for not starting anticoagulation. Okay. Um, in terms of anticoagulation, you have different medications. You have the Coumadin. INR should be between 2 to 3. You have the Eliquis if your weight above 60, if your creatinine, if your weight below 60, creatinine above more than 1.6, age more than 80. If you have two of these, 2.5 twice a day, everything else is 5 twice a day. Okay, everything else is 5 twice a day. You have Pradaxa, 150 if your GFR more than 30, 150 twice a day, less than 30, 75 twice a day. And you have the Xarelto GFR below 50, 15 twice a day, GFR above 50, 20, I'm sorry, 15 once a day, GFR above 50, okay, GFR above 50, 20 once a day, GFR below 50, between 15 to 50, then Xarelto 15 once a day. Then Savesa, we don't really use it very much. But the one that I like to use is, or I like to use always, is really Eliquis, because is safer when it comes to bleeding risk. So always you can choose one of these medications. If you're elderly patient, you can do 2.5 twice a day if you feel that 2.5 is indicated. And again, creatinine more than 1.6, age more than 80, weight less than 60 kilogram. If you have two of those, you can do 2.5 twice a day. And be careful, don't do 2.5 twice a day for everybody, because actually they found that meta-analysis that the relative risk is about 4 times in terms of stroke between 5 twice a day versus 2.5 twice a day if it's not indicated to use 2.5 twice a day. So don't use smaller dose in people that they don't qualify based on the package insert. Now, in terms of end-stage kidney disease, the two medications that you can use is Eliquis and Coumadin. So you can still use Eliquis, and it's really FDA approved to use Eliquis in these patients. There's new data about the Xarelto 10 milligram once a day, but you know, as far as the last updated guidelines in 2019, they mentioned Coumadin and Eliquis. Now for atrial fibrillation, in terms of rhythm versus rate control, you have to think about the following. They did a Afib trial in 2002, and this Afib trial, they found that doesn't really matter if you do rate versus rhythm control as long as the heart rate is well controlled. And nowadays we become very aggressive in terms of ablation and so forth. So we'd like to do ablations in patients who are a little bit younger, because, you know, the outcome is going to be better in terms of heart failure, admissions, in terms of stroke risk, and in terms of even dementia. Actually, if you do rhythm control with ablation, the outcome is going to be better. But for you guys, if you see patient with atrial fibrillation, you have to also think about, is it really persistent or paroxysmal, or you know, what we call long-lasting persistence. So if your AFib lasts more than 7 days each episode, then that's persistent. If your AFib lasting less than 7 days, it's paroxysmal. Anything beyond 1 year is long-lasting persistent. For you, I would use persistent versus paroxysmal. So if you have a patient with atrial fibrillation, heart rate at times like 130, 140, and then at times is like normal sinus rhythm, 60 to 70. In this patient, you know, you have to chest vascular your patient, and you can use some kind of rate control. And probably you can also use rhythm control for this patient as well. So, you know, it's really up to what kind of patient you have, but you know, for the nursing home patients, probably elderly, I would try to control the rate as much as I can, and unless the rhythm becomes an issue, meaning that whenever the patient is in atrial fibrillation, heart rate is so fast, in that case, you may need to use medication to, you know, keep him in sinus rhythm as much as you can. Now, when it comes to heart rhythm medications, you have different heart rhythm medications. You have the class 1, class 2, class 3, and class 4. I really want you to recommend to remember a couple things. The 3 medications that you have to think about in your settings are the propafenone, flecainide, and amiodarone. So propafenone, flecainide are class 1C medications. Amiodarone is mainly class 3 medication, potassium channel blocker. So the flecainide, propafenone, you should not have it coronary artery disease or issues with your ejection fraction to be able to use these medications. So basically, in your elderly patients, you have to be very, very careful. In the CAST trial in 1992, they found that if your patient has coronary artery disease or decreased ejection fraction and use propafenone or flecainide, you have higher chance of mortality. So it's extremely dangerous to do that. You have to be very, very careful. So always remember coronary artery disease, history of MI, and decreased ejection fraction. These medications are not to be used. These medications are not to be used. It's black box warning. In this case, your note goes to God forbid something happen, your note goes to the reviewer, and then the reviewer for the court is going to say, "Oh, black box warning. How come you used it?" So you have to be very careful. Okay. Now, in elderly patients, amiodarone seems to be safe or safer, right? You know, amiodarone has long-term side effects: eyes, thyroid, liver, and lung. And these side effects, they tend to be longer in terms of, you know, you have to use your medication 5, 6, 7 years. So if you have somebody who's 80 or 78 or 92 or 85 and they are nursing home residents, I would probably try to use amiodarone if you think that your patient is going to benefit from rhythm control strategy, in the sense that every couple of weeks, heart rate goes all the way to 120, 130, and patient feels miserable, dizziness, shortness of breath, fatigue, and about to go to the hospital. So always think about that, because sometimes, you know, you really can't use a lot of rate control medications in these patients because of blood pressure. And the amiodarone does not really affect your blood pressure that much. So you can always use amiodarone. You can say, okay, I'll use amiodarone 400 twice a day for a week. And then beyond that, I'll cut down to 200 once a day. Or you feel that you're dealing with 92-year-old lady who's fragile and who's, you know, who weighs 60 kilograms, you can do 200 twice a day for a week and then cut down to 200 once a day after that. So it's kind of art how you can manage that. We don't really like digoxin as a rate control agent because digoxin actually has long half-life and it's actually excreted via the kidneys. And in these patients, you can't just guarantee normal kidney function. And there are, you know, certainly weekly changes in kidney function. They get dehydrated, they get medications, they get whatever they have chronic kidney disease. Unless you have ability to be able to check your digoxin level every week or so, I would not really use digoxin. You can use cardizem or calcium channel blockers, cardizem, verapamil, and or beta blockers. You have to be careful. If your ejection fraction below 50, you cannot use the calcium channel blockers because of the chronotropic effect and the negative chronotropic and inotropic effect on the heart. Beta blockers you can use in these patients. So you just be careful how you're going to handle this. You can always use metoprolol 25 twice a day and uptitrate as needed. You can use you know, heart monitor to see your average heart rate. Based on the old guidelines, they say that the heart rate should be less than 80 at rest, 110 at mild to moderate exercise. There's a trial called Lenient Trial, 2012, New England Journal of Medicine, I think, and they found that actually your heart rate at rest, if it is below 110, you know, the outcome is going to be the same. Patients were studied for 3 years only. So I tend to see that 110 probably is a little bit on the higher side. So I would try to control the heart rate below 110, below 100 if I can. So you can uptitrate your medications to be able to achieve this goal. And remember, ejection fraction is low. You cannot use flecainide, you cannot use propafenone, you cannot use cardizem, you cannot use verapamil. Ejection fraction is normal. You can use a bunch of other medications, okay? Beta blockers always safer, right? And amiodarone in elderly patients should be a reasonable option. I would always try to avoid digoxin in these patients. I really want to mention something about the blood thinners that Eliquis is less excreted in the kidneys than Pradaxa and Xarelto. So if you have kidney issues, Eliquis is your friend. And things that most of the time that the Eliquis is probably safer than others. When it comes to managing atrial fibrillation, when the heart rate continues to be elevated and can't be controlled, in that case, probably evenodal ablation and pacemaker is needed. And you have to think about this kind of option if your patient continues to have issue. If your patient continues to have issue in spite of maximum medical management, the likelihood of doing that at the nursing home facility is probably small. So what I would do, I would keep up titrating medications, encourage hydration, and visit your patient once or twice a week and up titrate medication until you achieve reasonable heart rate control. Always you have to be mindful about the fact that if you think your patient has atrial fibrillation, these patients should have a CHA2DS2-VASc score, in the chart. And if there's an indication for anticoagulation, you have to start anticoagulation. If you don't want to start anticoagulation, you have to justify in your note why you're not starting anticoagulation in this patient. It's really complex when it comes to atrial fibrillation management, but Afib is disease of the elderly. We start actually having new treatments when it comes to anticoagulation. Patient who can't take anticoagulation, we can give them the Watchman device implant option. We're very aggressive here in Jacksonville with this. We tend to use it a lot. Certainly, if your patient is demented or half demented or bedridden, there's really no point of doing that. But if your patient is reasonably active, even at the nursing home facility, I think is not bad option to offer this Watchman device procedure. For when it comes to atrial fibrillation ablation, I tell my patients here in the clinic that before 2000, managing atrial fibrillation used to be holding hands. But nowadays, you can actually target certain areas in the heart and do what we call pulmonary vein isolation. And the idea behind the pulmonary vein isolation is the fact that in 1998, a French electrophysiologist by name Hezigar did study on 64 patients. So he put them in the lab, each one of them for about 24 hours with about 8 to 10 catheters in each one of them. And he studied the actually origin of atrial fibrillation. All of them, they had paroxysmal atrial fibrillation. He found that almost 80% of them had the Afib starting in from the pulmonary vein when you have this connection between the pulmonary vein and the left atrium. So they said, okay, how about if we ablate around it and prevent this kind of bad electricity from happening? And actually, it was interesting that Afib was prevented. In fact, actually on Monday, I had a case that the right superior pulmonary vein was isolated. After isolation, his patient started having Afib in the right pulmonary vein, right superior pulmonary vein. And the vein was isolated, so that bad electricity was not able to get transmitted to the heart. The heart maintained sinus rhythm. So it was extremely interesting. I've seen it probably 3 to 4 times throughout my career. But these are the new treatments that we try to offer our ablation for our patients. Certainly, this kind of treatment, you don't want to offer it to somebody in the nursing home. They are bedridden and so forth. You really need to maximize your medical management before you move to aggressive kind of deal. And be very careful. Atrial fibrillation may mask urosepsis, sepsis, underlying issues, so dehydration, hypovolemia, infection. So in your nursing home patients, you have to always be careful about, how to handle atrial fibrillation in these patients. So if somebody is known to have atrial fibrillation, it's in the records, patient doesn't look febrile, blood pressure is okay, I would not send this patient out if heart rate 120, 130, 140. I would try to manage that medically and, start up titrating medications because the heart is very resilient muscle and can handle it. But make no mistake, if your patient is having urosepsis, was not able to urinate, and blood pressure is on the lower side, and here there's some increased heart rate, and everybody's focusing on the heart rate, forgetting about the rest. You're trying to manage heart rate with beta blockers and calcium channel blockers and stuff like that, and then your patient might actually end up dying because of missing sepsis. So you always look at your patient, but if you think the atrial fibrillation is, the main culprit in these pictures, then you really don't need to send your patient to the hospital. They're gonna do the same crap. Start some cardism and this and that, get echo, give some fluids, and then go from there. But for you, you can actually do the same at the nursing home facility by starting some cardism, beta blockers. You should be able to look at the records, identify ejection fraction, score your patient, make sure blood thinners are there. If blood thinners are not there, you should justify why this patient is not on blood thinners, and up titrate medications, and time is going to be in your favor. So start some cardism today. Tomorrow cardism is not working, then up titrate the cardism, start some metoprolol and so forth. So there are a lot of ways you can manage it. And again, atrial fibrillation is very, very kind of complex. But if you, in your mind, always think about three things: stroke risk, rhythm, rate, you'll be successful. Ejection fraction should be there. Um, uh, and, up titrating medications and CHAS-BAS score. Otherwise, you really don't need to worry about anything else. And always keep in your mind that Afib can mask, can be the presenting symptom for or presenting issue for underlying severe illness, especially in these kind of elderly people. Do you have questions, guys?
I have one, Dr. Ibrahim.
Yeah.
So in the setting of HFpEF, when you know the ejecting fraction is good,
Yeah.
would you still avoid using diltiazem?
No,
Or
you can.
okay.
Yep, you can. No, you can use it. And you can use flecainide and propafenone. They don't like flecainide if your wall thickness in the left ventricle more than 1.3 centimeter. So it kind of, becomes freaking tedious sometimes, but, just if you think the heart is healthy, ejection fraction is fine, no CAD disease, you can try some flecainide and see how your patient does. But you have to be very, very careful about these kind of medications in the setting of coronary artery disease or decreased ejection fraction because they are really contraindicated. Anything else?
Do you use Sotolol often?
Yes, a lot.
Okay.
Whoever works with me in the clinic, I use it a lot.
Okay.
So if you want to use it, you have to make sure that sotalol is kidney, actually, it's excreted via the kidney, right? So you have to be careful about up titrating the medications. So you can use 40 twice a day and get another EKG in a week. And if the QTC interval is less than 500, you can up titrate to 80 twice a day. At the nursing home patients, I would never use more than 80 twice a day. You have to have a kidney function. Creatinine should be less than 2. GFR should be fine or reasonable. But if you have chronic kidney disease and elderly patient, I would try to be very careful. And actually, it was recommended for patients with coronary artery disease and preserved ejection fraction, even though we sometimes use it for little bit decreased ejection fraction if we think that the decrease because of atrial fibrillation. But in general, yeah, I used it a lot actually, and I used a lot of dofetilide too, but dofetilide is very, very complex, so you should not really use it yourself.
So I have a question about anticoagulation in a patient that came in bleeding in Compass.
Yeah.
Yeah, so this guy, he's morbidly obese. He came in with, he has a history of a PE 2 years ago, was on Eliquis and did fine. He's got a right cephalic thrombus right now. He's in atrial fibrillation, and he came in with melena. His H&H has been stable the last 2 days. So I'm concerned he's really high risk for CV event. So I'm concerned starting
So-
him back on Eliquis.
Did they figure out the etiology for the melena, or just probably?
Well, they found a huge abdominal mass today. He has a history of renal cell carcinoma.
Mhm.
Yeah, but he
No.
doesn't want any aggressive measures.
Sure, I would not use it.
So don't even start it.
No.
Okay.
So, if you CHA2DS2-VASc score him, there's multiple actually indications for the blood thinners in his case. History of PE probably related to the fact that he has cancer, which
Mhm.
likely so. And then the atrial fibrillation with what you said, MCA stroke.
Yeah, this is another guy. No, that I haven't gone over the MCA stroke yet. This is another one I was concerned with.
No stroke. No stroke.
No, this guy doesn't have a stroke.
Yeah. So the CHA2DS2-VASc score maybe 4 or 5. That will
He's
give you
4. Yeah, his
four.
his is 4.
That'll give you about probably 8 to 10% per year of having stroke. But the risk of melena and having bad outcome is extremely high. So I
Yeah.
recommend very high risk of
Okay.
complications and just stop it.
Okay. Now the other guy, he came in with a MCA stroke bilateral, and he had a Watchman placed 2 years ago,
Damn.
and they're thinking it's cardioembolic.
So
He's from Holiday, Florida, so I'm not sure what hospital he was at.
so that's really tough one.
Right.
Bilateral is cardiac, you're right. So here's how actually that's a prime example of what we said about the atrial fibrillation and the stroke risk. Carotid, usually unilateral, but if you have something cardiac, you maybe diffuse, but remember I said diffuse, massive, bad. Bilateral is usually diffuse and cardiac etiology. So when they did the studies a long time ago, they found about 91% of atrial fibrillation related strokes form in the left atrial appendage. Still, you have 9% coming from somewhere else, right? And if you compare the 99%, that you're going to have coming from somewhere else versus the risk of blood thinners, so the Watchman actually won. But this kind of case is isolated case where, does he have, PFO, ASD, this patient, or there's something else that we're missing, or there any antiphospholipid syndrome giving him like thrombosis or stuff like that. So it's kind of tough, but this patient probably bought himself anticoagulation for the rest of his life.
Okay.
One though, but I think this patient should have to have anticoagulation. There's a concept started a few years ago about what we call atriopathy. In other words, the atria are so bad and they're acting like left atrial appendage, all of them. And in that case, the stroke risk is high and anticoagulation probably needed in these patients. It really did not really make it to the guidelines, but there are multiple reasons. And certainly this case is extremely isolated. We really don't see it very much.
Okay. All right. Thanks.
Sure.
I have a question.
Yes.
Probably simpler, but your time frame as far as how long someone is in AFib. I had a patient where we assumed she went into AFib. She was in the 150s. And of course, in this environment, it's a little bit slower to get an EKG.
You're right.
By the time they had gotten it, she was in sinus. So as far as starting anticoagulation
No,
on something like
No,
that.
be very careful. If you
Mhm.
don't see it, it doesn't happen. It didn't happen. So you see it on heart monitor, you see it on EKG, you see it on loop recorder, you see it somebody like that. I would do loop recorder probably. You see it on device interrogation, yes. But you know, the janitor said that I've seen heart rate of 150, and I'm just trying to make a joke of it. If you don't see it, you don't start blood thinners. You don't,
Okay.
and be very careful about that. You don't see it, you don't start blood thinners. You can document in your chart, somebody said the heart rate is that. You don't know, it could be AVNRT, could be VT, could be atrial tach. So could be MAT.
Her EF came back. They did an echo. Her EF came back at 30 to 35, and she's got a history of cancer on chemo, and you know, quite a few things going on. So
Yeah.
I
Yeah, I mean, that's a really tough one, but I would not start blood thinners based on, I've seen it where actually, you know, people go with anxiety, ladies in their 70s, heart rate 120, and then all of a sudden labeled with AFib. Why? Do you see EKG? No, I don't see it. Okay, then you don't have it unless you see it.
got you. Okay.
Would you talk a minute about when you may decrease Eliquis dose based on hemoglobin?
Yes, so you're right, damn shit. So, you know, and as far as I'm concerned, anything below 8, you should not start blood thinners. Okay. I think between 8 to 10, you have to think about cutting the dose of blood thinners. Above 10, you're fine. I think between 8 to 10, you probably consider, thinking about, if it is like 9.5 and stable 9.5, leave it alone, but 8.9, 8.7, I think probably Eliquis should be decreased to 2.5 twice a day. Xarelto should be decreased to 15, even to 10 once a day. I mean, Pradaxa should be decreased to 75 twice a day. So this is when you have to individualize therapy and, tailor your therapy based on your patient, and especially your patient elderly. I mean, these patients, they can really bleed easily and they can suffer miserably from, decreased hemoglobin. And if you feel that the hemoglobin is a little bit on the lower side and there's some leak somewhere, then probably cutting down the blood thinners is not a bad idea. But as far as I'm concerned, hemoglobin below 8, I would document that. I would not use blood thinners.
But what about Plavix?
So Plavix, it depends on the indication of Plavix. So now,
CAD.
yes, so CAD, okay. I'm biased a little bit. I'm electrophysiologist, and I can tell you that these geniuses from intervention cardiology, they really don't fucking get it. So the new generation of the stents, they are very, very good, very good. And there are solid studies that beyond 1 month, you don't need dual interpreted therapy. In guidelines right now, actually between 3 to 6 months, guidelines. And the guidelines are a little bit lagged behind, the real data. But we have multiple studies right now that dual antiplatelet therapy is reasonable for 1 month. Beyond that, only single agent. And if you think that your patient is bleeding on Plavix, change to aspirin. And if you think that there are dual antiplatelet therapy, stent is not really recent, within 4 weeks, stop one of them. Stop one of them. I mean, document that. I mean, patients bleeding, hemoglobin is 7.9 or 8.2. Come on, man. I mean, it's gonna be, patient will feel miserable. So you have to be, I mean, remember the new stents nowadays, they are very, very, very good, very good. One time when I was in training, actually, I did presentation about stenting and the history of PCI. And when they started doing stenting in the late 80s, early 90s, stent thrombosis was 16%. Pretty damn high, right? Now you don't even hear about it. Why? Because stents are very, very solid, very good.
I have a similar question. So I have a few nursing home patients who have a remote history of GI bleeding, but recent labs show hemoglobin's good. There's no, at least apparent bleeding in the history. I mean, maybe a colt, but I mean, would that be some situation where you'd be okay with resuming anticoagulation
Sure.
when it was stopped before?
Sure. You always remember, I talk about that in the clinic and here. You know, always medicine is about intervention. Do intervention, see how you do. Do another intervention, see how you do. And then start blood thinners, check hemoglobin in 1 week, and then check hemoglobin in 2, 3 weeks, 4 weeks. And then, stepwise, especially in these patients, you really need to be very careful. They have, one time I was in rounding and one of my mentors actually told us, okay, what is the #1 risk factor for mortality? Shay, what is the #1 risk factor for mortality? How you look? What do you think? Ejection fraction, CAD, history of cabbage, aortic valve stenosis? Age. Age always is extremely important. Elderly people, you have to, I say it, you have to treat them with like baby fingers. You have to be very, very, very careful how you deal with them. And, you have to have a stepwise approach. You start something, start slowly and progressive. And, make more visits. You swing by, next week, and the week after, and then you're in the same building in a couple times a week, then swing by the same patient and check on that patient. And, you're really doing a huge service for this patient because, some of these patients, actually, they can deteriorate extremely fast. And, Nick had a case where, can you share your case? The dehydrated lady.
Sure. So one of my buildings, gentleman I was seeing, the nurse told me he wasn't really acting right. We followed him for Afib and had some hypertension. And he wasn't eating and he was pretty lethargic, and I read in the notes that he had fallen recently. Primary was called and it didn't look like it did anything. So I, ordered EKG, was a little bit tachycardic, blood pressure was borderline low, ordered some stat labs, and turns out the guy was extremely dehydrated. Creatinine base was around 1.6, came back around 3.6, and dehydrated to the point where the hemoglobin was around 20. So, I saw the guy probably 4 or 5 times over 2 weeks, gave him some fluids, communicated with the primary, and definitely prevented hospitalization.
Yeah.
Maybe even,
Yeah,
the guy
severe
died.
hyperkalemia. Yeah.
Yeah.
So, always remember these patients, they can be dehydrated. These patients, they can have multiple issues. If you're gonna focus on the tachycardia itself, you're gonna lose your patient. So look at the whole picture. Why this patient is tachycardic? Okay, history of Afib,
Christ.
so I would really be very careful. Any other questions, guys?
Yes, why some AFib patient has pacemaker?
Why? Yeah, if you look at the natural history of Afib, if you do have Afib, lifelong need for pacemaker is 20 to 25%. And they say because of the etiology. So the infiltration, the fibrosis that creates the atrial fibrillation affects the sinus node and make you have sinus node dysfunction. So there's a close association as pathophysiology between the need of pacemaker, sinus node dysfunction, and atrial fibrillation.
Okay.
Any more questions, guys?